So the topic today is the same as metastatic spine disease, and we were discussing last time that a case can come to you either as a viva or in your clinical practice that somebody like this one, a 70-year female, uh, while bending at home, just got sudden pain and then presented with these X-rays. And these X-rays obviously showing a classical vertebral compression fracture there. So we last time discussed how do we diagnose uh, this problem? What are the differential diagnoses? So we last time we discussed that the common thing for this differential diagnosis we have to think about are Nihal, you were there last time. What are the common things? What is the common thing we are talking about?
First is osteoporosis, then second was osteomalacia.
So osteoporosis is the top, and osteomalacia less common, but after osteoporosis, probably secondaries in a 70 year, isn't
Yes,
it?
secondaries.
Yeah. And then come the other less common
Infection.
osteomalacia, infection, and very rarely primary tumor of the bone, not secondary, primary of the vertebral tumor as itself. And we also, in secondary, we also included multiple myeloma as a part of it. So we discussed that we have to take a detailed history and ask few questions. And first is ask these three questions in the diagnosis. First, could it be uh, not metastatic, which means could it be osteoporotic? Could it be infected? And could it be a metabolic like osteomalacia? So we discussed what are the points in the history suggestive that this is osteoporotic, infective, metabolic, secondaries. So what are the points in the history? What are the points in examination? And then blood test, and then X-rays, and then come to a diagnosis of that. This is a secondary. So first is rule out infection, metabolic, osteoporosis. Then rule out the possibility of now most of you can mute yourself if that's okay. You can mute yourself. Uh, Prashant, you are mainly participating. Is that right?
Yeah, yes, sir.
Okay. So we discussed. You were there last time, were you?
Yeah, yes, sir. I was.
Yeah. So first thing is to say, could it be one of these three, osteoporotic, which is the most common, and infective, especially tuberculosis infection in India, because sometimes tuberculosis start with the vertebral body. Most of the time we discuss the infection
Paradiscal,
involving paradiscal,
paradiscal.
whereas the malignancy will be in the body, but tuberculosis also can start in the interior body and can present similar vertebral planar type things. And metabolic like osteomalacia or secondary osteoporosis, like somebody on the glucose steroids and things like that. Once you have ruled out that this is not one of these, then you have to see could it be the rare, some very rare time, sometime it can be primary bone tumor. Primary bone tumor are like all the bone tumor you know of, but in 70-year-old, probably it is the commonest is chondrosarcoma, whereas in young children, obviously, is the osteosarcoma and Ewing's tumors. But in this 78 groups where you are differentiating with secondaries, it will be a chondrosarcoma, which will be in your mind as a primary bone tumor. And then if your third question is that if it is not a primary bone tumor, if it is not one of the three osteoporotic, infective, metabolic, then most likely it is secondaries. And then if it is secondary, then again you have to ask two questions. Where is the primary coming from? And if it is secondary, then is it just one metastasis or there are many metastases in other bone and other spine? So whether it's a solitary or multiple. So that is where we ended last time, that we have reached up to here, that this is a metastasis. So we have done all the diagnosis. We said what are the after history and physical examination, what are the usual battery of investigation we do, Suresh?
usually we
You want to be
do
called
a
Prashant or Suresh?
Prashant, sir. Prashant, sir.
Prashant. So Prashant, what are the investigation you will do if it is not straightforward, osteoporotic or infective?
Yeah, first I'll rule with the blood panel, clinical history, radiological evaluation. Then we'll look out for the primary, sir.
Yeah, so same thing. History, very important. Then examination, and
Examination.
yeah, and then your lab test, X-ray, and other uh, imaging technique. Yeah.
Yes, sir.
So the history examination we discussed. What are the common lab tests we do if you want to, if you're suspecting secondaries?
So mainly hemogram, alkaline
Yeah.
phosphatase levels, parathermone levels.
Yeah.
For the
Yeah. So same thing. You want to rule out infection, metabolic, osteoporotic. Osteoporotic, all investigation will be normal, but in
carriage.
infective and metabolic, full blood count, ESR, CRP, in metabolic, parathyroid, calcium, total bone profile, alkaline phosphatase. Then, if you're thinking of secondaries, then common primary site tumor marker blood test like PSA. Yeah, if
Okay.
multiple myeloma markers like
Urine electrophoresis.
electrophoresis, Jones protein in the urine. So these are the things you're looking for in your blood test, usual blood test. Yeah,
Oh,
and
okay.
then imaging in the clinic itself, you will do an X-ray. An X-ray can differentiate between an osteoporotic and infection and a primary and secondary tumor with some features which we discussed last time. And then you will do higher investigation such as MRI scan of the whole spine and to know where primary coming from, and also to stage this we do three CTs: CT abdomen, chest, pelvis. So that will, most of the time, even if you don't know the primary, it will tell you where the primary coming from, and it will also tell you if there is any other metastasis in the liver, for example, or in the chest. So CT chest, CT abdomen, CT pelvis. On it will also tell you the common primary, which is a chest is a common, renal is a common, thyroid you will do if it is suspecting, then you do thyroid function test and ultrasound of the thyroid. And so thyroid, chest, breast. If you're suspecting a lump there on your palpation, then you do mammogram of the breast. Then come prostate. We already said you do PSA of this. And if you're doing CT chest abdomen, it will also tell you whether the primary tumor lying in the chest or in the kidneys or anywhere in the gastrointestinal tract. So these are the common investigation you will do: full blood count, ESR, CRP, PSA, immune electrophoresis of the blood and urine, Jones protein, and CT scan for abdomen, chest, pelvis. Once you've done the localized X-rays and MRIs of the whole spine. So these are the battery of tests you will do. And after this test, you will find the primary most of the time. And if you still not find a primary, then next you will do the biopsy of the spine. So this is what we discussed till last time. And if you come with all these up to biopsy, you may not need all these things. You may stop. Sometimes just history examination and a plain X-ray is enough. So if you got a person coming to you, 70-year lady with previous multiple osteoporotic, and on your examination, there is no evidence on the history, there's no evidence, red flag sign suggestive of infection or malignancy, and all five organ you have seen, the common organ from where the primary come, and there's no suspicion, no weight loss, no significant pain before she had these symptoms. Before that, there was no pain at all, and she has previous osteoporosis, then you don't need to do any other test. You stop at X-ray. If you get night pain previous to this fracture, and there's a fever, then obviously you have to investigate for infection. So ESR, CRP, and bone and MRI scan, and then biopsy to take a sample to see what kind of infection it is. Then you don't need CT abdomen, chest, pelvis. But if this is not suggestive of anything and you are highly suspecting a secondaries, then you do CT. So this is not test in every case. Every case need a detailed history and examination. Every case need an X-ray. Yeah. And then lab investigation is very selective. But if you have ruled out metabolic, infection, osteoporotic, then you need this battery of tests we mentioned. And if after this you cannot find a primary, then you need a biopsy to confirm where is the primary coming from it. So most of the time you do a biopsy, either X-ray control or nowadays CT guided biopsy. So once you had come to this stage, so let's say we have come to this, then we have to ask three more questions. So three questions for diagnosis were that: could it be osteoporotic, infective, metabolic? Could it be a very rare primary disease? And if it is a secondary, which is the common, where is the primary? And is it a solitary or is it a multiple? So these are the questions we have asked as a diagnosis. Then we come, and the level 2 is the management or treatment. Then in the treatment depend on what is this causing to the skeleton. What is the problem it is causing to skeleton, and we call this skeletal related events for bone secondaries, either in the limb or in the spine. We call them skeletal related events. And then we somehow to assess how much this patient is life expectancy, because if the expectancy of life is very short, then there's no point doing a big surgery. And if it is a medium, then there's only point doing some palliative surgery. And if it is a long, then we have to think that the implant you're putting is not going to fracture because the patient has to live for say 4 year or 5 year of his life. Yeah. So you need to decide life expectancy, what is the skeletal related events, and is there any other way this tumor will respond to? So most of the tumor which come to the bone as a secondary are actually carcinoma from these 5 organ. On the 5 organ we said thyroid, breast, lungs,
prostate.
prostate, and renal. So these are the common one which come, and so we need to find out whether they are mainly radio sensitive or not. Nowadays we also got some chemotherapy and some anti-resorptive medicine like bisphosphonates. So how they will react to these is also important. So what is the tumor? How is the tumor will react to, mainly to radiotherapy, because a lot of these tumor will get radiotherapy either on their own or along with your surgical intervention. So when we say response to non-surgical treatment, mainly we're talking about response to radiotherapy, whether they will respond or not. So these are the three questions. If you know, you can manage the treatment. So one by one, we will go to these questions. But the treatment are the mainly three treatments again. Treatment could be simple radiotherapy. Treatment could be a palliative stabilization of the spine, and treatment could be a decompression plus stabilization. Okay. These are the three treatment mostly done for. So if a patient has got very short life, when we say 3 months only, then most of the time you will just doing a radiotherapy. Yeah. If the patient has got, and we will discuss this, mainly here we're talking about stability of the spine and the neurological symptoms. So when you're talking about SRE, skeletal related events, what are the SRE you can expect if a patient's got secondaries in the bone? When we're talking SRE, mean what are the symptoms they can have, or what are the sign or symptoms? So, Prashant, what can happen if the bone secondaries come to spine?
Patient might have functional pain or
Yeah.
a pathological fracture.
Yeah.
The,
So the spine also very important, whether they're compressing the spinal cord.
yeah, pediclopathies and myelopathies.
Radiculopathy or myelopathy or neurological deficit.
Right.
Yeah. Yeah. So pain, and the pain could be because of the tumor itself, or rather than pathological fracture, which we discuss normally in the long bone. Here we say whether this has made the spine unstable. Yeah, stability of the spine. So it's if the stability, and these two pain are very different. So could you tell me a difference between a pain just from the tumor without disturbing the stability versus a pain which has disturbed the stability? What will be the difference, Prashant?
The pain which occurs due to instability will be a functional pain, sir.
It will be called mechanical pain. So that means
Mechanicals.
as soon as patient stand, his pain get worse. And if he rest, it get better. Yeah. So
Yes.
if he want to walk or stand, he just get worse. If he's sitting or lying down, it get better. Whereas the pain because of tumor without affecting the instability is a relentless pain getting worse in the night. So it get worse in the rest.
Not,
Yeah. So
yes.
both are bad if a patient got secondaries. Then if the pain is worse in the night, they are bad, or it could be sometime a combination. You're difficult to make out. But if the patient say, I can't even stand, I have to just sit down, that means the spine is unstable. That means as soon as he loading it, it's getting painful. Yeah. So those are the things you need to see. So let's go one by one. SRE, life expectancy, and response to surgical treatment. And there are a lot of scoring system and a lot of things in the bone secondaries which is asked in the exam. And I'll try to simplify it. What are the things you need to know minimum? But the thing is that all these things are within these three things. What is the bone? What is the tumor doing to bone, which is SRE? What is the skeletal related events? How is the life expectancy? And how does this tumor respond to radiotherapy or other therapy other than surgery? So these are the three things we need to know. So this we already discussed. This is, we said, this is a infection because this is involving the disc space. So we discussed this last time. Infection, this is tumor, this is a tumor. These are the five big organ from where it comes. If it involve the posterior element, especially the pedicle, then it's most likely tumor like the winking owl we see. So these are some of the features we discussed last time. So once we made this diagnosis, we are going now the treatment. So the skeletal related events in the extremity we discussed when we discussed extremity, but in the spine, there are two. One is just pain. We discussed two type of pain, mechanical pain and pain because of the tumor. Then, as you mentioned, pathological or impending fracture, which we called instability. So this will be a instability suggestive of, if it is mechanical pain, it's suggestive of instability. Whereas if it is just severe pain, not getting better and worse in the night, then that means this is a pain just because the tumor eroding the bone. And the other things like bone marrow aplasia will be also same as in as it was aplastic anemia as you see in the extremity. But important other thing is that spinal cord compression, and most of the time this is an epidural. It is not intramedullary or it is an extramedullary epidural compression. Yeah.
Yes.
So we're talking about epidural spinal cord compression. So spinal cord compression, which you can see in MRI, and we'll discuss that. And then obviously these are the skeletal related events you're looking for. So two things you have to, especially in the spine, look for three things. One is pain. How severe is the pain? Two is instability, and three is the spinal cord compression. So again, three things you're looking at skeletal related events, especially in the spine, other than the extremity. Here, you're looking for these things: pain, the instability pain and spinal cord compression. And just like in the extremity, when we talk about impending fracture, here instability also got a scoring system. So do you know the Mirror score, Prashant?
Yes, sir.
Yeah, Mirror score we
Yeah.
used for the long bones. Yeah.
Long bones prophylactic fixation.
Yeah, so that has got which side, where is the pain, what is the lesion doing, so side, upper limb, lower limb, peritrochanteric. We give points, pain mild, moderate, severe, lesion blastic, mixed lytic, and size one third, one third. So these are the points we gave for Mirror score. Here you need to remember one score, instability score, or spinal instability score, or called SINS. Okay, so like Mirror score, you remember here what is the score for instability?
Spinal instability score.
Yeah, so here also same thing location. There was upper limb, lower limb, and pertrochanteric. Here we decide whether it's a junction. When it is junction, you get high score. So junction, where can be junction of the spine? Cervical with the occiput, occiput with the thoracic, thoracic with the lumbar, lumbar with the sacral. Yeah, so these are the junctional. If the lesion is there, they are very unstable. Then is it in a mobile spine? So cervical spine is very mobile, and lumbar spine is very mobile. Thoracic spine is reasonably less mobile. So they get a little less point if it is thoracic, and very rigid. So sacral has no movements on it. Yeah. So depending on where this is, again, you don't need this. Just remember Mirror score here, location, and just remember that if it is in the junctional area, it is very unstable. Then pain same, mild, moderate, severe, and here very similar you can describe. The bone lesion same, blastic, mixed, and lytic. And here we say how much collapse is there. There we were saying how much is the one third, two third, less than one third. Here we're saying how much collapse. Again, no need to know exact the scoring system, but these are the variable you need to know: location, pain, lesion, and vertebral collapse. Yeah, but these are just not four. Since is based on six, whereas Mirror is on four. So what are other two things you add to it? You add first whether there is any kyphosis or scoliosis or any deformity. So you also add a deformity to it, whether there's, and then whether there is any posterior element involved, because so far we only talking about the vertebral bodies, but what about the posterior element, whether they are involved? So involvement of posterior element and spinal alignment we add to this, and that gives you a SIN score. We can know whether the spine is stable or unstable. So that's one thing you need to know, the spinal instability scoring system. And this scoring system you combined with the second thing was, one was the pain, the second was instability, third was spinal cord compression. So spinal cord compression, very simple. Nowadays we do MRI. If it is the tumor is just touching the cord, or whether it's compressing some of the cord, or it's completely all around the cord. So we just say mild, moderate, severe, and this is called epidural spinal cord compression. Okay, so this is a grading system. So you got a grading system for instability. Pain, obviously, you say mild, moderate, severe, and you got a grading system for spinal cord compression. So these are the skeletal related events. So you have somehow graded them. Skeletal related event, you have graded them. The second thing you have to find out is the life expectancy of the patient, and third thing is the tumor itself, whether it's radio resistance or radio sensitive. Okay. So let's now do the second thing. So life expectancy, how do you calculate life expectancy? Do you know anything, Prashant?
Expectancy. No, sir. No.
So one of the simple thing people say that how good is the patient? Can he walk? Is he completely in the bed? So there are parameter people have made, and this is one scoring system, a simple called a performance status, that how good is the patient. So if you again don't need to know the thing that if it is very good, then they score about 80 to 100%. It's just like your 12th class mark. If you got moderate, 70, and if you are very poor, you failed. Yeah.
Yeah.
So this is a very commonly used scoring system called Karnofsky scale of performance. Yeah. So you
Okay.
grade this, and obviously, if it is very short life, then you will only give radiotherapy. If it is very intermediate life, then you will fix it. But if it is a very long life, then you will do something better than just fixing, or fix it very strongly so that it doesn't break before patient break. Okay.